You're welcome to the reproductive health section of Today on STV. It's great to be here this morning, and we'll be discussing a very interesting topic. But before I start that, I'd like to appreciate all those who have sent me emails, all those who have called me and SMS. It's wonderful to hear from you. It's always wonderful to do that. So keep sending your emails, keep sending your text messages, and I will respond to as many of them as I can. I also understand the confidential nature of some of the things you discuss with me, so some of them I might not be able to relay on air. Well, like I said, today we are discussing a very interesting topic. My name is Abayomi Ajayi. I'm a consultant obstetrician and gynecologist. And we're talking today about assisted reproductive technology. What does it mean? What are the things that is entailed in the assisted reproductive technology? But before I just do that, I want to mention a few things. You know, we've been discussing on how to investigate patients who are faced with this challenge of infertility. So today I'll just mention two things that we use, what we call endoscopy, or laparoscopy and hysteroscopy. These big names, what it just means, when we talk about laparoscopy, we're talking about a surgical procedure that allows doctors to look inside the abdomen or pelvis without having to cut through. You know, we call it pinhole surgery sometimes. So it can be used for diagnosis, and also it can be used for treatment. You can use it to treat almost anything when we talk about laparoscopy. Anything that is in the pelvis or is in the abdomen, yes. We can use it for ectopic pregnancy. We can use it to treat cysts. You don't need to actually be cut open when you have an ovarian cyst. It's possible for us to do laparoscopy and bring out the cyst. You know, so like I said, it can be used for ectopic pregnancy as well, and of course it can be used for in other parts of causes of infertility to break down additions and so on and so forth. And the second thing is hysteroscopy, which is like a thin telescope which can be passed through the vagina into the uterus, and this can diagnose whether you have what we call Asherman's or Asherman syndrome or additions, that is scar in the endometrium, the lining of the uterus. Whether you have polyps in the uterus, that can be diagnosed and also can be treated at the same time, both for the Asherman's. The best way to treat Asherman's, I'm sure one day we're going to have a topic on Asherman syndrome, which we're going to discuss what this means and because I know there's a lot of women out there that one of the problems that they have is what we call Asherman syndrome. We're going to treat it as a topic one of these days. Then if you have polyps or fibroids, that also can be taken care of with the hysteroscope. So the endoscope or the hysteroscope and the laparoscope are just telescopes. They're like telescopes which we can use to either go into the abdomen or go into the uterus. And we can use this for diagnosis and we can use it for treatment. Now, like I said, what we're discussing today is actually assisted reproductive technology. Now, assisted reproductive technology, or techniques that make up assisted reproductive technology. For any method, for any procedure to qualify to be called assisted reproductive technology, or is that a technique of assisted reproduction, it must have three characteristics. There must be drugs used to achieve what we call superovulation. We know that a woman will most of the time only make one egg every cycle. But if we want to do assisted reproduction, we need to produce as many eggs as possible. Now, get this right. It's not as if we are going to deplete your stock, because it's like the ovary operates in cohorts. So every month, when you are in a cycle, it's like a cohort of eggs that would be used for that cycle. So what we're just doing is to recruit as many as possible, because if you are left alone, you are only going to make only one. But when we give you drugs, you are able to make more. So when you use these drugs, it does not in any way make you to reach menopause early. Then that's with the superovulation. Then the second characteristic of any method that will be qualified for assisted reproduction is that there must be a method of sperm preparation. And then there must be a method to bring the sperm and the eggs together. Now, depending on how complex this third characteristic is, then we have about 3 prototypes of assisted reproductive technology. The most basic and the simplest is what we call intrauterine insemination, which just involves that we prepare the sperm, and around the time that you are supposed to be ovulating, we inject it into the uterus. Now, if the sperm is not prepared, this could be very dangerous. So it's important that it's not just any doctor who can do this. The person needs to be trained. And intrauterine insemination can be useful when there are ovulatory disorders, when the woman is not ovulating, or when there is unexplained infertility. We have done our investigations, we can't see what it's causing the infertility. And also when, in some cases where intercourse is not possible. For instance, if the man has what we call retrograde ejaculation and the sperm is falling into the bladder instead of coming out, or the woman has what we call vaginismus, it's impossible for the man to be able to penetrate. Those are some of the times that we use intrauterine insemination. But I must add a note of caution here that intrauterine insemination cannot be used when the man has very low sperm count, and can never be used when the woman has blocked tubes. So the success rate of intrauterine insemination is about 15% per cycle, or we say about 33% of people who use intrauterine insemination will be pregnant after about 4 attempts, cumulatively. So we can see, don't forget where we started from, that the normal fertility, if you like, rate in couples is about 18 to 20% every month. So we're talking here that it's just about what you will get when there is no problem, that we're talking about just a little bit below, about 15%. Now, the second kind of assisted reproductive technique that we'll be talking about is what we call IVF, which is about the commonest form of ART, or assisted reproductive technique. This was used initially for tubal blockage. You remember the story in 1978, the first baby that was born from IVF was born in 1978, and the mother had the 2 tubes had been cut off from ectopic pregnancy. Now, but we know we can use IVF for many other things. For instance, in endometriosis, when unexplained infertility, when there are some minor sperm problems, and sometimes when you have done about 3-4 cycles of IUI, they fail, then you need to progress to something higher, which is IVF. Now, here, the difference between IUI and IVF, that in IUI, you are injecting the sperm into the uterus, and the sperm are like finding their way to the tubes where fertilization takes place. In IVF, you are going to bring out the egg from the woman. That's why it's called in vitro fertilization outside the body. You are bringing out the eggs from the woman outside the body, and you are joining it with the sperm from the man, everything happening outside the body. And so now when you now have embryos that you now transfer back into the woman, and in about 25% of the time, this goes on to become a baby. Now, let's look at the steps that are involved in IVF. The first step, like we said, is superovulation. You must make more than 1 egg. This, usually we employ a number of drugs to achieve this. After that, then we must pick up the eggs. Now, the eggs that were produced, we pick them through the vagina. We don't cut the women. We use scanner to be able to locate and identify them, and we bring them out through the vagina without cutting. We use a form of sedation, but we don't use general anesthesia. Now, when we have the sperm and we have the eggs, then fertilization must take place in the laboratory, just like I said earlier on. Now, after the fertilization has taken place, we have an embryo, then we must transfer the embryo back into the uterus, and from there, this now goes on to, the body decides whether it wants to accept it or it wants to reject it, because don't forget, what we have actually presented to the body is like a pregnancy, what we call an embryo. And now we need to support this until we do a pregnancy test about 2 weeks later. And like I said, when we do that, in about 25 to 30% of the time, this continues to become a baby. So today we have been able to look at a few things. We have been able to discuss about endoscopy. We have been able to discuss about assisted reproductive technology, especially we've talked about intrauterine insemination, and we have talked about in vitro fertilization or IVF. Well, until I see you next week, don't touch that dial. See you.